Okay, so my name's Ahmed Hassan. I'm one of the neurologists at Leeds Teaching Hospitals. So I'm going to just give you an overview of the evidence for why we're here and trying to learn about interventional treatments. And we're really talking about large artery occlusion. So these are the kind of patients that we're interested in picking up and referring for the appropriate treatment. But it's important to remember that large artery occlusion only accounts for about 50% of stroke patients that come through A&E. So the others are going to be, for example, lacuna strokes or smaller branches that we can't see on the CT angiogram. And so of these, the ones that we kind of maybe going to send for intervention, it's going to be about 25% that are going to be in the middle cerebral artery. So we know that when we see large artery occlusion or large vessel occlusion, that we're kind of worried about these patients. In terms of the natural history, if you have, if you see a large vessel occlusion on CTA, we know those patients are going to do badly, and that's independent really of even the stroke severity. So we know that with higher NIHSS, there is a worse chance of doing having a good outcome. But if you have a large vessel occlusion on top, then the outcome is even worse. And that applies both in terms of the functional outcome and also mortality as well. So there's a kind of a gradient or an interaction between the NIHSS and the presence of large artery occlusion on CTA. And we know that you're going to have a poor outcome also with TPA as well. So if you have if you don't see large artery occlusion, then there is a fairly good chance that with IV TPA you're going to have a better recovery, probably because you're dealing with small volume clot in these M3 branches, whereas if you're getting occlusion in the middle cerebral, the M1 segment of the middle cerebral artery, then the chances of doing well with TPA by itself are less good. And we do. That's what we have really, mainly IV thrombolysis. That's what we have at our disposal. And there's no doubt that it is an effective treatment. So even though we're here talking about intervention, we still need to remember, have at the forefront of our mind that we do have a treatment that works for many of our stroke patients. But there is a debate in terms of who benefits more than others, and who may be harmed, who we should be referring for more aggressive treatment. And the other thing to remember is that when you see a large artery occlusion, if we know that's associated with a poor outcome, but if you recanalize the artery, that is associated with a good outcome. Seems that it's not rocket science, but we know that recanalization does occur spontaneously. So even in patients who have large artery occlusion and you don't do anything, if you repeat the CT angiogram after a day or two, quite a significant proportion of those patients will have recanalization, but they're not, it's not meaningful recanalization, so they're not opening the artery within a window of time where you're going to make a difference in terms of salvaging tissue. So we know that about 50% of patients, if you repeat the CT angiogram and you don't do anything, they're going to have recanalization. And the more aggressive you are, then the proportion that you get recanalization increases. So with kind of mechanical techniques, you can get kind of a joke, isn't it? The interventional radiologist says, "Well, I've opened the artery." They're very good at opening the artery, but what we're interested in is really opening those arteries within a very quick time to make a difference to the patient. So really, that's where the kind of a bit of a background as to where we're going with this talk in terms of where we want to get. We know that occlusion is bad and recanalization is good, and so that's been the impetus for developing aggressive techniques in terms of opening up the arteries. And in 2013, there was 3 trials presented at the International Stroke Conference in America, and these trials were all negative. So there was a kind of a bit of a despondency at that stage, and the kind of problems and explanations that were given for these negative trials were that the intervention, these trials took a long time to recruit, and some of them have been going on for 5 or 6 years. So they were using techniques that were not really applicable in the practice, even in 2013. So devices such as the multi-mercy kind of corkscrew device. So there was worries that these were devices associated with more trauma and bleeding. Maybe that was one explanation. Perhaps there wasn't an appreciation that timing was of the essence with interventional treatment, not just recanalization. Patients were perhaps in some of these studies not selected properly. So the IMS3 trial, for example, many patients were recruited at the beginning. CT angiography was not really in widespread use, so the patients were actually just on the suspicion that they had large artery occlusion going into the catheter lab, and then they were having angios and they didn't have any target lesion to treat. But those patients would still go in the intention to treat analysis of the study. So poor patient selection, so no target. So if you haven't got a target, you're not going to show a difference between the 2 treatment arms, and possibly who was doing these procedures. So were they experienced? I mean, some of these issues were dealt with in the later studies, as I'll mention. But there was some encouraging data from IMS3, even though overall it was a negative study, because when they took all the patients who had confirmed large artery occlusion on CTA, so there was maybe 250 patients, they did show that there was a difference between endovascular treatment and just giving intravenous. So this is endovascular plus IV in many cases. So you can see that there was a difference, and this was hopeful, but obviously no one's going to really be changing practice just on the basis of a post hoc analysis. And so basically in IMS3 the devices that were being used were, for example, the multi-mercy device, but by 2012 stent retrievers were being used. So this led to the kind of question as to whether the wrong techniques were being used to remove the clot. And so one of the studies which you probably should know about is where they did a head-to-head comparison between the multi-mercy device and the solitaire device. So these are kind of try to ensnare the clot in a mesh and remove it, and much quicker and less traumatic probably where the occlusion is. And so this is not a trial. It's not a study looking at a control group. It's just comparing 2 interventional techniques, and they found in this study that the solitaire device was much more effective in terms of getting a good functional outcome compared to the Mercy retriever. So that was a stage really in 2013, and NICE issued this guidance because I think some centres have started doing thrombectomies, and they kind of issued this kind of woolly advice really, which just said that thrombectomy should be used only with special arrangements for clinical governance, consent audit or research, for in patients whose thrombolysis is unsuitable or has failed. So, it doesn't really, that in itself wouldn't stop you from doing a thrombectomy, I suppose, because how long do you wait for if decide whether it's not worked, I mean, on the way to the cath lab. But I suppose the key here was, clinical governance consent and audit. So if you were doing it, you'd have pathways to maybe be recording the data in, for example, a registry such as the SITS thrombectomy registry. But I think what they're really perhaps were encouraging centres to do was to randomise patients into a trial, and the one that was kind of running or about to start in the UK was the PEACE trial. So I think some centres had decided already that they were going to just do the treatment, and some centres, like in Leeds, we kind of had been doing some thrombectomies, but we then decided that we would put our weight behind PEACE. But I mean, the game changer really was, last year when Mr. Clean was presented at the World Stroke Congress. So this was, the trial that really, starting to, led the, kind of a domino effect with, some of the other trials, as I'll mention. But this was so patients being well selected. So, for example, they had to have the target lesion that we're interested in, a large vessel occlusion. So demonstrated on CT angiography. So they were randomized into either best medical treatment or best medical treatment plus intra-arterial. And when these patients came through the front door, so they all had TPA, but there was the clinician felt that the treatment hadn't worked, or it doesn't really. We don't know how long they waited for to decide that the treatment hadn't worked, but there was a feeling that IV thrombolysis had not achieved the outcome, and so the patients were then randomised into either continue with best medical therapy or go on to the cath lab. And so their kind of endpoint was a good functional outcome of MRS 0 to 2. And you can see that there was a very striking difference between the best medical treatment and the group that were offered thrombectomy, and similar rates of intracerebral hemorrhage. Overall, this study didn't show that mortality had changed. And as you can see, compared to the IMS3 study, the stent retrievers were being used in this study in the vast majority of the patients. In terms of what kind of patients were recruited into the study, and for example, it was a big study, where there are some patients that we shouldn't be offering thrombectomy to. Mark's going to talk about this later, but across whatever subgroup was looked at, they found that there was a benefit. So we're getting kind of into some small numbers here, but you see that there's kind of no, these boxes don't go into the favouring the TPA arm. Just some points to note. There's quite a few patients in this study who had cervical ICA occlusion, so this is not covered in some of the other trials, and there was a definite benefit. Patients who were older, so even kind of extreme elderly, 80 above the age of 80, so even doing better. Perhaps there's a trend for them even doing better than some of the younger patients. So, just a few things. So this study didn't show that there's one group that you shouldn't be doing thrombectomy on, but it's worth remembering that to get into the study, you had to have a good base. You had to, MRS more than 3. That was the kind of situation in 2014, and there were a number of other trials, that were ongoing, which were, trying to test this hypothesis that IA treatment was better than IV, and you can imagine, in cardiology they do big trials, thousands of patients. I mean, if you add up all the numbers in these trials, you're probably going to get 6,000 patients. And up to that point, about 1,600 had been recruited. And a lot of these studies, the ones for anterior circulation stroke, were kind of stopped at that point after Mr. Clean, because I think equipoise was lost, and the data monitoring committees kind of looked at the data and kind of stopped recruitment. So the study the UK study, Peace, I think was stopped. The recruitment had been very slow, and I think they only got up to about 60 patients. But in a number of the other studies, there was sufficient recruitment, and when they kind of looked at the data, they had reached the kind of stopping criteria for when the control and the interventional group, there was a difference that couldn't be explained by chance, which had been pre-specified at the start of the study. So I'll just run through the trials quickly. So you probably just need to know the names, maybe some subtle differences between the trials. Escape. So this was probably the study that got the most patients, 316. It's a pragmatic trial, so looked at patients, the kind of techniques that we have routinely available in our centres, so CT and then CT angiogram, and using the CT angiogram to kind of give information about collaterals, and also this plain CT to give information about maybe what the infarct core looks like by using the aspect score. So perhaps if you use the CT angiogram to look at the collaterals and the core, and the CT brain to look at the core, you can get an idea of what whether the penumbra is going to be of a significant size to make treatment worthwhile. So the entry criteria is less than 12 hours from onset to being able to achieve the treatment. Again, stent retriever used in the vast majority. Again, a significant difference between the control and the intervention group. Extend IA was a study which used basically a technique using CT to basically, again, define a group where you think they're going to benefit from interventional treatment. So they, instead of using CT angiography to kind of select their patients, they used CT perfusion and computer software to kind of estimate the size of the penumbra. And so basically, it was a small study, and they only kind of recruited 35 patients into each arm, but before the study was stopped, and despite that, in this well kind of defined population, they showed that there was a significant difference between the control and the interventional group. Swift Prime, again, using CT. Most of the patients had information on the penumbra as well, using a similar technique to the other study. This, again, good functional outcome in the 60% of patients who had interventional treatment, so very significant treatment effect, and markedly reduced mortality. Most of these studies, as we'll come on to later, the kind of target lesion was in the M1 artery. So those were the kind of 3 studies that were kind of followed on from Mr. Clean, and then this year at the European Stroke Conference in Glasgow, they presented another 3 studies which kind of provided kind of overwhelming evidence that thrombectomy is better than just best medical treatment. So Revascat was a Spanish study, which again, so these studies specified that the patients who were randomized, the clinician had to feel that TPA had failed. So in this study, they waited 30 minutes after giving TPA to see whether there was any signs of improvement, and if not, then they were randomized. One of the things we're going to talk about later is, again, some of these studies are using the aspect score, so looking at the CT early ischemic changes, seeing if there's minimal early ischemic changes to define a good group where they've got no irreversible damage. So in the treatment arm, 43.7% had a good favourable outcome against about 30% in controls. This study, Thrace, is is not published yet, but they presented preliminary data at European Stroke Congress. So another big study, 414 patients. They waited 60 minutes before deciding that TPA had failed. And again, the intervention had to be performed within 5 hours, so a shorter time window than some of the other studies. They didn't use any specific criteria for pre-selecting patients, so based on the aspect score. And again, most of these patients had M1 occlusion.
How did they decide they failed TPA? So was that based on NIH or just?
So basically, it was clinician felt that the patient had. I mean, there was no, they didn't have to have like a 50% improvement or anything like that. They just decided that, in their opinion, the patient had not responded well enough. So it was kind of a pragmatic. So those are all the trials which have used kind of, large proportion have used stent retrievers. There was one other study which was presented which used suction catheter, so penumbra. And again, this study was didn't reach kind of significance because what happened was that I think by that stage, a lot of the other thrombectomy trials had presented their data and they were showing strongly positive effects. So I think this study was stopped because there was just complete loss of equipoise at that point. It was not felt ethical to continue. But they kind of, as well as anterior circulation, large vessel occlusion, they kind of had to specify that the clot was a quite sizable size, 8 millimeters. So what this study showed was that using the suction catheter as the first line treatment and then any other intervention that the radiologist felt was needed, there was a trend towards the intervention being better than the intravenous thrombolysis. But probably, the study was not powered at this number of patients to actually show a difference. But the trend is, it's all going in the same direction compared to the other studies. So I've just summarised all of that in one chart, and I mean, there's kind of the evidence is kind of unequivocal that thrombectomy is, on top of best medical treatment, has a better outcome than just TPA or standard medical care. And the difference between the two colours really is the treatment effect. And you can see that there is a variation in the treatment effect, and that can be explained by lots of different factors. So, for example, how quickly the patients were processed in terms of stroke onset to groin puncture. So you can imagine that the studies where the clinician just waited, for half an hour or an hour to see whether the thrombolysis had worked, that inevitably led to a delay to the groin puncture. So in those studies, perhaps there may be not as big a treatment effect. And the other thing is, in the studies where the patients were kind of very highly selected and whittled down, for example, from 7,000 patients, you're getting down to just like a few patients who are actually included, can be included in the studies, highly selected, then obviously you're going to get more of a treatment effect because you're almost kind of picking out the patients who you think you're going to do well with your treatment. But I suppose we're not interested in the difference between the studies, but just that they're all going in the same direction. So we're kind of left with, does the treatment work? Yes. Who does it work for? Well, we know that Mr. Clean, for example, showed that it works across a whole range of patients. But for example, within the NHS, we probably need to think about who these treatments we're going to apply to, and there probably are some other unanswered questions. So, which patients should we select? Should we just, give the treatment to everybody, or should we, on a pragmatic basis, or should we try and select patients out based on their imaging criteria? And if we're going to use imaging, what's the best imaging modality? So across the trials, they use different ways of selecting out the patients. Should we just use CTA, which is available in all centres, or should we use more advanced perfusion techniques to try and define the penumbra? to see who's going to most benefit from these treatments. There's other questions. So, for example, what's the best anaesthetic technique? So there's evidence from Mr. Clean that general anaesthetic, if you give general anaesthetic, the patients did worse. Perhaps that's to do with finding an anaesthetist and getting all that set up, adding more time, or perhaps it's just something to do with general anaesthetic causing drop in blood pressure. We know that most of the patients, M1 occlusion, does it benefit other types of occlusions? So we talked about basilar artery occlusion. There's a trial that's still ongoing, trying to recruit called BASICS, looking at thrombectomy and basilar. These smaller branch occlusions, in many of these studies, they didn't look at extracranial ICA occlusion. So Mr. Clean did include a subset of patients, but should this be a factor in influencing our decisions? Age, how do we define the penumbra and the size of the actual irreversibly infarcted tissue? And what's the best way of implementing this treatment in the NHS? What are the pathways that we should be trying to set up locally and within regions to kind of give these treatments, give patients access to these treatments rather than just where people are kind of committed and kind of taking the time out and enthusiastic about them. So in conclusion, several trials in different countries. I've kind of given you an overview. They're all kind of going in the same direction. There's pragmatic trials and trials where they kind of super selected their patients because they really wanted to make sure that they were really giving a positive result. Overall, the take-home message is that if you're going to send these patients for treatment, time is of the essence. Early, more effective recanalization is likely to be the key. Good patient selection. It seems to be a safe treatment. So there's no excessive mortality or bleeding that we're seeing in the interventional treatments. So how can we deliver this treatment in the NHS and make it more generalisable from the trials? So, thank you.